So, good day everyone. Today we are going to talk about something important in our body, the jaw joint or the temporomandibular joint, which we call it as a TMJ for short. So, there is a condition related to TMJ that is known as ankylosis. So, ankylosis might sound a big word, but it simply means a joint that becomes very stiff and that cannot move properly. That is TMJ ankylosis. So think of TMJ like a hinge that helps us open and close our mouth smoothly. But sometimes, due to certain reason, this joint can really get stiff or even stop moving altogether. So that is what we call it as ankylosis. So ankylosis, a situation where our jaw does not work as it should. So ankylosis happen when something goes wrong with the joint. It can be so the term ankylosis. Remember, it means it is a pathological condition where the mandible uh, it is fused to the fossa by bony or fibrous tissue. So ankylosis, it is a Greek word that it means stiff joint. Now the ankylosis, it happens when something go wrong with our joint. So it can be due to a few things like injuries, infection or diseases affecting the joint. So these problems can make the joint freeze up or fuse together, that make it tough to open our mouth or move our jaws comfortably. Now imagine having difficulty chewing your food uh, or not being able to speak properly because your jaw does not move well. That is what the people with ankylosis might experience. So let's break down ankylosis of TMJ. The ankylosis of TMJ, it refers to the fusion or the stiffening of the jaw that essentially limits or completely stops its movement. So just picture this, your jaw being unable to move as freely as it should be. So this condition can cause significant issues with your jaw functionally, uh, from restrictive movement to even the inability to fully open your mouth. Now ankylosis, it interferes with the mastication, speech, oral hygiene, or the growth and development. So ankylosis occurs due to various reasons. It might be a result of trauma. So the most common cause is trauma, infections, or developmental problems affecting the particular joint. So when we are talking about the intra-articular TMJ ankylosis, we are referring to the fusion or adhesion between the condyle and the glenoid fossa. Now here interesting trend in some part of the world, like in the western countries, the incidence of the TMJ ankylosis seems to be decreasing. So this decline is it is due to the better management of the jaw fracture and a decrease in the middle ear infection, mainly due to the introduction and widespread use of antibiotics. However, in countries like the India, the incidence of TMJ ankylosis, it remains relatively high. So reported case range from as early as 2-year-old to late as 63 years of age, with the onset often observed between the age of 10 to 15 years of age. So this indicates that the condition can affect the individual from very young age and impact their jaw function as well as growth. So managing TMJ ankylosis, it is a complex process that involves a team of specialists including oral and maxillofacial surgeons, orthodontics, and sometimes physiotherapists. So remember, for your entrance exam, the childhood trauma or it is considered as the major cause of the ankylosis. Now the ankylosis, it can be either defined as true ankylosis or the false ankylosis. So we have to distinguish between the false ankylosis. So this categorization refers to whether the joint is actually fused or just appear so due to the muscle spasm or the scarring around the joint. The true ankylosis, when there is fibrous or osseous adhesion between the surface of joint, and false when the ankylosis is due to other pathologies that are not directly related to the joint. The intra-articular ankylosis refers when the fusion between the actual articular surface, when there is a fusion between the actual articular surface of the joint, whereas the extra-articular results from the issue affecting structures outside the joints itself. Now let us talk about the nature of fusion or the union within the joint surfaces. They can be either fibrous or union or bony. The fibrous ankylosis involves the fusion of joint by the fibrous tissue, whereas the bony ankylosis, it refers to the fusion that is caused by deposition of bone between the head of condyle and the glenoid fossa. So when we discuss whether the ankylosis affect one side or both side of joint, we refer it as unilateral or bilateral. Now, what are the main causes of TMJ ankylosis? Remember, the two primary factors stand out as major contributing to the development of TMJ ankylosis. The first is the trauma and other is the infections. So, according to the report by the Topesian, 26 to 70% of TMJ ankylosis were linked due to the trauma, while the 44 to 68% were associated with the infection. Infection can arise secondarily due to the septicemia resulting from the conditions such as osteomyelitis, that is infection of bone and bone marrow. Other systemic infections like septic sore mouth, scarlet fever, tuberculosis, meningitis, and similar illness, they can lead to joint infection affecting the TMJ joint. Now, the infection within or around the joint can cause inflammatory response, leading to damage or scarring of the joint tissue. If it is left untreated or inadequately managed, these inflammatory processes can ultimately result in formation of the fibrous joint or the bony deposit that can lead to fusion or the union of the joint surface. That is a hallmark of TMJ ankylosis. So remember trauma, it is significant factor in the development of TMJ ankylosis. That includes the injuries or damage to the joint area due to accident, fractures, dislocations, or the surgical procedure involving the joint or the joint itself. Trauma, it can disrupt a normal structure and function of joint, leading to fusion of the joint surfaces. Firstly, the joint infection, it can arise in the several ways. They might result from the systemic infections like the osteomyelitis, septic sore throat, scarlet fever, tuberculosis, meningitis. So these conditions can lead to bloodstream infections that may affect the TMJ. Moreover, infections, they can spread directly from nearby areas. Infections from the middle ear infections, osteomyelitis of temporal bone, parotid abscess, skin infections, all can extend to the TMJ that can cause inflammation and damage to the joint structures. Moving to disease that affect the joint themselves, conditions like rheumatoid arthritis, ankylosing spondylitis, arthritis. These are the degenerative diseases that can bring about changes within the TMJ that may lead to destruction of the joint, a disc, and subsequent repair process. So these changes can ultimately result in the ankylosis of TMJ, limiting its movement and functionality. Now let us talk about trauma. A significant percent of TMJ ankylosis can arise from the traumatic injuries, like even at birth, trauma to TMJ might occur, like due to the forceps injury. Trauma during the prenatal life can lead to congenital ankylosis, affecting the joint development from an early stage. Later in the life, facial injuries involving the fracture of the condyle neck head can contribute to ankylosis. So direct impact on the joint chin area can lead to bleeding into the joint space. So this hemorrhage can initiate undesirable changes, including the blood clot and a deposition of the bone. So if the jaw movement it is restricted for extended period, fusion between the joint surfaces it can occur. Individual prolonged immobilization following the condylar fractures, especially in the children with their rich blood supply, increases the risk of bleeding into the joint space. That can also lead to the ankylosis. So when the trauma occurs, there is significant injury to the TMJ that leads to the leakage of blood into the joint space. So that is known as arthrosis. So over the time, if the joint remains immobilized for extended period, there will be initial fibrous band that forms due to the trauma that can progress further. These fibrous bands may mainly lead to the bony concentration or ossification, further restricting the joint movement. So what started as an response to injury with the fibrous band may result in the formation of bone, resulting in the fusion of the joint space. In the case of intra-articular ankylosis, where the fusion occurs within the joint itself, several changes can take place. The meniscus, that is a structure that helps to cushion and stabilize the joint, undergo progressive destruction. So this destruction can cause flattening of the glenoid fossa and thickening of the head of condyle. So that results in narrowing or even complete obliteration of the joint space. In some cases, the bony fusion may extend beyond the joint space. It can involve the other structures like the cranial base, sigmoid notch, zygomatic arch, and even part of skull. So these are the mechanism of TMJ ankylosis. It can occur due to the trauma that could lead to the bleeding, hemarthrosis with the formation of connective tissue, and could lead to fibrous or bony ankylosis. Similarly, the infections that can lead to fibrocartilage reabsorption and ultimately lead to fibrous or bony ankylosis. Now, we classify the TMJ ankylosis can be classified based upon the Topazian, or the Sonic classification. Topazian classification, stage 1, when the ankylotic bone it is limited to the condylar process. So this one is stage 1. This one is the stage 2, when ankylotic bone extended to the sigmoid notch, and stage 3 is when the ankylotic bone it extends to the coronoid process. While Sonic classification is type 1, type 2, type 3 and type 4. The type 1 is extensive fibrous adhesion around the joint. So you can see a fibrous adhesion around the joint. Type 2 is more bony fusion at the outer edge of the articular surface. So outer edge of the articular surface, but there is no fusion within the medial area of the joint. Third is the bony bridge between the mandible and the temporal bone. So when there is a bony bridge formation between the mandible and the temporal bone, it's the type 3. And type 4, when the joint it is replaced by mass of bone, it's the type 4 classification. Other is Al-Hakim classification, class 1, class 2, class 3 and class 4. Remember that? Now how can you diagnose this ankylosis? Identifying a TMJ ankylosis involves a thorough clinical examination, typically restricted oral opening or completely inability to open the mouth. It's the key feature. Patient often complained of difficulty in chewing due to this limitation. Movements like protrusion of jaw, they are not possible on the affected site. While palpating the joint, one can often detect the partial mobility or complete immobility of the condyle. In the young patient, the nature of the facial deformity, it can help to differentiate between the unilateral and bilateral involvement. An interesting point to note is that the individual in whom ankylosis develop after full growth completion usually do not exhibit facial deformity. The unilateral ankylosis is typically observed in children or individuals where the condition began in the childhood, presenting with the distinctive sign and manifestation. The most evident sign is the facial asymmetry. So most evident point is the facial asymmetry that you can know that you can notice. So due to the restrictive movement of the affected side, there is often deviation of the mandible and chin toward the affected side. The chin may be receded with hypoplastic mandible. That's the feature of the unilateral ankylosis. There is rounding and the symmetry can lead to rounded and fuller appearance of the face on the affected side. So you can see the fullness on the affected side. The unaffected side may grow flatter, elongated. This side is flatter, elongated due to the compensatory growth. Apart from that, you can see a concavity along the lower border. So this concavity along the lower border of the mandible, it's the antegonal notch. So the diagnosis of TMJ ankylosis, it is based upon the history. It is important to differentiate between the true and pseudo ankylosis. History of trauma directly to joints could lead to injuries that may result in ankylosis. Ear infections, history of ear infections, that is otitis media. So chronic or severe ear infection, especially if left untreated, can lead to nearby structures that results in TMJ ankylosis. So there could be inflammatory process or infections near the joint that can lead to ankylosis. Forceps deliveries during the childbirth can lead to pressure on the baby head, and that can lead to trauma or injury to the TMJ. Extracapsular causes like conditions like zygomatic arch fracture, oral submucous fibrosis, they should be ruled out. The clinical examination involves the imaging studies like X-ray, CT, MRI that can be done. The clinical examination of patients suspected of having ankylosis involves assessing the various signs and symptoms related to the clinical findings. There could be restricted mouth opening. So one of the primary indication of TMJ ankylosis is limited range of motion in opening and closing mouth. The patient will experience significant difficulty in opening their mouth that would lead to restricted jaw movement that can interfere with the speaking, eating, etc. Other is the obstructive sleep apnea. There is an observed association with the TMJ disorder, particularly the ankylosis and the obstructive sleep apnea. So that condition involves interrupted breathing during sleep due to temporary collapse or obstruction of the airway. So this altered anatomy and restricted jaw movement, it can contribute to the airway blockage that results in the obstructive sleep apnea. Patients are often seen with craniofacial syndrome, skeleton deformities. These all can involve the abnormal growth or development of the facial bone that can impact the TMJ structures or the function. Psychological stress, chronic pain, functional limitations, especially ankylosis, anxiety, depression, psychological distress can also challenge in performing the oral function and also alter the facial appearance. A scar over the chin might indicate a history of trauma or TMJ ankylosis. Now what are the diagnostic methods that we can use? One is the OPG we can use. Other is lateral oblique view. That helps to view the anterior posterior dimension of the condylar mass. It is useful to evaluate any elongation of the coronoid process. Other is we can use CT scans that we will discuss later on. Now what are the types of ankylosis? Ankylosis can be either unilateral or bilateral. So imagine someone with an issue that is known as unilateral ankylosis. That means the one side of their jaw is not moving properly. So what are the things that you will notice about their face? First of all, you will likely see that their face is not quite the same on both sides. There is facial asymmetry, which means one side looks different from the other. So one of the key signs of this condition is that their chin looks like a pointing or leaning more toward the side that's affected. So the chin is deviated to the affected side. That is the feature of the unilateral ankylosis. However, on the unaffected side, there will be elongation and flattening on the other side. So you can see so this one is the affected side. So chin would be deviated to this side. There would be fullness on this side, whereas on opposite side there will be flatness. So on the side where everything is okay, you might see something a little bit flatter and longer than the other side of the face. So well-defined anticolon notch, it is present in the unilateral ankylosis. When someone has this condition, the joints on the affected side does not move as it should. So if they try to open and close their mouth, their side does not move as much at all. So the movements of joint, they are pretty much absent. So because of the jaw, they not moving properly on one side, it can affect how the teeth they come together. So that might have what that is known as unilateral posterior crow's bite. So in the unilateral ankylosis, what you will see is the facial asymmetry. Ankylosis affecting the one side of jaw, leading to facial asymmetry due to the imbalance in the jaw, growth and function, the deviation of the mandible and chin towards the affected side due to the restricted movement that causes a shift in position of the lower jaw. The chin is receded on the affected side. The affected side may exhibit hypoplasia of the jawbone leading to receded chin and a smaller mandible. There is roundness and fullness on the face on the affected side. The affected side may appear fuller or rounded as compared to the unaffected side, as discussed here. Whereas the opposite side is flattened and elongated. So in case of the TMJ ankylosis, where there is restriction in the jaw movement, the depressor muscle which pulls the jaw down and become relatively stronger compared to the elevator muscles that lift the jaw. So this balance in the muscle function can cause the depressor muscle to exert more pressure on the lateral aspect of mandible, leading to noticeable concavity or the notch. So that is known as an antigonial notch. So this antigonial notch, remember, it is well defined in unilateral ankylosis and it is prominently bilaterally seen in case of bilateral ankylosis. Now, in the bilateral ankylosis, the mandible is symmetrical and it is micrognathic. So when someone has this condition, they gradually find it harder and harder to open their mouth. It's like the space between the front teeth, it gets smaller and smaller over the time. So that causes the face to look like a bird face when the chin appears to pull back or recede. So this one, the chin, it's pull back, that leads to bird face appearance. The mandible is retrognathic, the antigonar notch is bilaterally seen, and there is inability to open the mouth. So their mouth is it's tough for them. It's often less than, mouth opening is often less than 5 mm wide. So that makes it challenging to open, eat or speak comfortably. Apart from that, there is a reduced or absent neck chin angle. So the angle between the neck and the chin, it's almost reduced or entirely absent due to the restricted jaw movement. The patient with the bilateral ankylosis commonly presents with the multiple carious teeth and poor periodontal health due to difference in the oral hygiene maintenance and limited access for the dental care. So when someone has TMJ ankylosis, the surgery, it is the main way to fix it. Fixing it early is really important if we want to make sure that they can use their jaw properly again. So how will the doctor decide to do the surgery? Depend upon the few things. First, they should think about when the ankylosis started. So this helps them understand how long the problem has been there and how much it might have affected the jaw. Next, they should check how much amount of jaw it is stuck because of the ankylosis. Some people might have only one side. Some people have only one side while others have both sides of the jaw affected. So they also consider if there are any changes in the way the person face look like because of the ankylosis. Sometimes the jaw problem can change how a person face grows or look. So now based on all these things, the doctors would plan for surgery. They might need to do different type of surgeries or techniques. For example, if the ankylosis it is not very severe, then they might remove the stuck part of the joint and help the jaw move better. But if there is more serious, they might need to do more complex surgeries to fix the joint, and even uh, maybe improve the way the face looks. Now, the surgical strategy that depends upon the following: first of all, the age of the patient. Second is extent of the ankylosis. Third is whether it is unilateral or it is bilateral. And last is the associated facial deformity. So imagine your jaw getting stuck, making it tough to open your mouth properly. The surgery will help to unstick or relieve the stuck part, making it easier for joint to move again. Surgeries, it aims to make the joint work well. Now let us discuss the various surgical approaches to TMJ. What are the various surgical approach that we can do to assess the TMJ? The first is the preauricular approach. The preauricular approach, it is a surgical technique that is used to assess the structure around the temporomandibular joint, the ear, and the adjacent facial structure. So this approach would provide adequate exposure for various procedures involving the TMJ, such as the joint surgeries, resection of tumors, or management of the facial fractures. The first of all that you should is what is the incision location for the preauricular incision. So the preauricular incision, it is made in the front of ear. So it's always in the front of ear. Second, what is the purpose of this incision? The primary purpose of this particular incision is to provide access to the TMJ area that are affected by the ankylosis. So the surgeons would create this incision carefully to ensure adequate exposure of the TMJ region. So this incision has various advantages. It allows the surgeons to navigate the tissue and structure around the TMJ. So that would provide a clear view and access to the joint while minimizing the risk of damaging the nearby nerves or the blood vessels. Now there are some modification to this TMJ approach that can be either Dingman's, Blair, Thoma, Alkayat-Bramley incision or Popwich incision. The first is the Blair incision. So let us discuss that. So these the pic represent the modifications. The first is the Blair and Abbey's inverted hockey stick incision. So imagine drawing a hockey stick, inverted hockey stick over the zygomatic arch area. So this incision is the Blair and Abbey's incision. So this incision would provide better access and visibility, making it easier to reach the zygomatic arch and the condylar region. The second is the Thomas incision. So this line shows the incision line. So this incision runs across the zygomatic arch, starting in the front of ear and extended slightly above the ear labule. So it is angulated in a way to avoid the main trunk of facial nerve, minimizing the risk of the nerve damage. The third is the Alkayat and Bramley modified preauricular incision. So this one is Alkayat Bramley incision. So Alkayat, he developed an adjusted approach considering the vessels and nerves nearby, particularly focusing on the branches of facial nerve and the vessels that are around the TM joint. So this one is the Alkayat and Bramley incision. Now let us talk why these modifications they are crucial. The facial nerve, we know it's a significant player here. It exits the skull and enters the parotid gland, branching into temporofacial and cervicofacial trunk. So during surgery, it is important to identify and avoid these branches to prevent the damage. The terminal branches of the facial nerve, temporal, zygomatic, buccal, marginal mandibular and cervical. We know these are essential to understand, especially during the TMJ surgery. So the temporal nerve branch, they are located within the tissue around the zygomatic arch. So the Al-Kayat and Bramley found that these branches typically around 2 centimeter from the front of the external ear. But they can vary from 0.8 to 3.5. Now to protect these nerves, surgeons they use precise incision. So by creating a larger incision in the temporal area, extending into the preauricular region. So that is Al-Kayat Bramley incision. The other is the Dingman's incision. So this one is the Dingman's incision. Basic incision for the preauricular approach. It involves incision made anteriorly to the ear, curving around the tragus, that is pointed eminence in the front of the ear canal, and extended backward into the hairline. So this incision would allow the access to TMJ but might not provide extensive approach. So in short, this Blair incision, it offers access to TMJ and the condylar region. The Thomas vertical incision, it avoids the main trunk of the facial nerve. The incision starts in the front of ear, extended across the zygomatic arch and curving upward. So that this angulation would allow for better exposure of TMJ and minimizing the risk of the facial nerve damage. The other is the post-auricular incision. So the post-auricular means the incision made behind the external ear. Post means behind and auricular means behind the external ear. So the the issues associated with the post-auricular approach are there is limited facial exposure that may lead to poor access and visibility. Additional, it can cause narrowing of the external ear canal, infection involving the ear canal, tingling or numbness in the outer ear. Other is the endural approach. This approach involves a shorter incision in the facial skin that extends into the external ear canal, starting above the zygomatic arch and move downward and backward into space between the tragus and the helix part of the external ear. So the benefit here is excellent cosmetic results, but it comes with a limitation like restricted access and possibility of ear canal narrowing or inflammation. The other is the submandibular approach, or it is known as Risdon approach. So this incision is the submandibular. These methods involve incision around 1 centimeter below the angle. So this one is the angle of the jawbone. So 1 centimeter below the angle of angle, and it moves forward, running parallel to the lower edge of the jawbone and curves slightly backward behind the angle. So this approach is to assess the neck of condyle. So it has drawbacks such as limited to access to the certain parts of jaw joints, particularly the head region. The other is the coronal approach, a surgical method that can be either unilateral, that is known as hemicoronal, and if it is bilateral, that is known as bicoronal. So this approach is used for surgery involving the upper and middle part of the facial skeleton like the zygomatic arch and TMJ. So a coronal approach, it provides access to the facial structures and so it provides excellent visibility and accessibility. And the most advantage of this approach is that the scar resulting from incision is hidden within the hairline. So when the incision extends into the preauricular region, the surgical scar becomes is not visible, which is beneficial for the cosmetic region. Other is the post ramal approach, that is behind the ramus. So suppose this one is the ramus and this is the post ramal approach. So it is indicated in the condylar neck fractures, condylectomy. Now other important, there was one more modification in the preauricular approaches, that was Popovich. Let us discuss that also. The Popovich incision, it is modification to approach, which is modification to approach used for the surgeries involving the zygomatic arch and the joint. So incision used in this approach is longer and wider than the traditional incision. It follows a question mark starting around the length of ear away from the length of ear. So what are the advantages of Popovich modification over the Al-Kayad-Bramley incision? First of all, there is reduced incidence of nerve damage. Second, it acts as a donor site for the temporalis fascia, provides a potential site for harvesting temporalis fascia. There is less bleeding, improved surgical clarity, reduced post-operative issue, and better cosmetic results. So these are the various incisions that can be given to assess the TMJ. Now let us discuss the how would you release the ankylosis. It can be done by two methods. One is condylectomy, in which the condyle it is detached and removed, and other is the gap arthroplasty. So what are the treatment options that are available for the ankylosis? The first is high condylectomy, second is gap arthroplasty, and third is the interpositional arthroplasty. Let us discuss them one by one. The first is condylectomy. Condylectomy means there is incision of the condyle portion only. So you can see here, so this when this condyle head part it is removed, that is known as condylectomy. So when is the condylectomy indicated? It is indicated when there is fibrous ankylosis. When fibrous spread, they will restrict the jaw joint movement without much condylar head deformity. When the spaces they are filled with the fibrous tissue, then when condylectomy is done. It can be done in case of severe osteoarthritis, various other forms of arthritis like the rheumatoid arthritis, and malunited condylar fracture with the limitation of the motions and pain during the mastication. So here the condylar head it is separated from the upper attachment. So what are the post-surgical effects? It may cause the jaw to deviate towards the operated side upon the opening of the mouth. In case of unilaterals, there is deviation of chin to affected side on the mouth opening. It could also lead to anterior open bite that occurs due to the loss in the height of the vertical lemma. So after mobilizing the fused joint through condylectomy, reshaping is done using the arthroplasty techniques. Other method is gap arthroplasty. So gap arthroplasty that refers to surgery where the cut it is made between the previous joint space and no material it is placed between these material it is placed between the joint surface. So two horizontal osteotomy cuts are made and a wedge-shaped piece of bone it is removed to create a gap between the roof of the glenoid fossa and the ramus. So remember, a gap of around how much size? 1 centimeter. It is recommended to prevent the re-ankylosis. So important for your entrance exam point, how much gap it is needed? It's 1 centimeter gap is required. That would prevent the re-ankylosis. So removing the bony wedge, it is a delicate work, especially the medial aspect near the internal maxillary artery. A large round burr it is used to thin the bone, followed by careful removal using a hand chisel or osteotome. So one thing that you have to ensure that the gap it has an equal dimension both the medially and the laterally. So that will this prevents the possibility of bone surface making a contact and causing re-ankylosis. So remember, a gap of 1 to 1.5 centimeter it is required. It is created. Remember, two horizontal bony cuts they are made in the most superior aspect of the ramus. The inferior cut should be made first, followed by the superior cut. Complication of a gap arthroplasty: excessive gaps may lead to anterior open bite. There may be re-ankylosis. The third is the interpositional arthroplasty. So in interpositional arthroplasty, experts suggested that placing something between the cut surface that would reduce the joint of the re-ankylosis, refusion. So creating similar to the gap arthroplasty, a gap it is made between the cut bone surfaces, and additionally a barrier it is placed between these surfaces to minimize the reoccurrence risk. Now what are these barriers? They can be either made from patient own body, that is can be autogenous, or synthetic material, that is the alloplastic. Apart from that, it helps to maintain the proper vertical height of the ramus. So various interpositional materials they can be autogenous, that includes temporalis muscles fascia, costochondral graft, dermis graft, facial sternoclavicular grafts. The alloplastic material can be either metallic or non-metallic. Metallic is titanium gold, and non-metallic it is made up of celestic acrylic. So for the autogenous part, it can be either muscles, fascia, skin, cartilage, or sternoclavicular metatarsal bone grafts, fat, etc. Xenograft can be also used, that consists of collagen and cartilage. So remember, the autogenous interpositional graft, they are the most commonly used material. Complication are there could be involvement of second surgical site, as the alloplastic material they will as the autografts can be taken from the patient's own body, so there could be second surgical site. Apart from that, in case of alloplastic, the foreign body reactions could be seen with. Now important next point is the series of steps that are related to the Kaban's protocol for managing the temporomandibular joint ankylosis. So the first is aggressive excision of the fibrous bony ankylotic mass. So that involves the surgical removal of the fibrous or bony mass that will cause the limitation of the jaw movement. Second is the coronoidectomy on the affected site. Coronoidectomy is the surgical removal of the coronoid process, which is the part of the lower jawbone. So that these steps aims to alleviate the restriction that is caused by the affected site. The third is coronoidectomy on the opposite side if step 1 and 2 does not result in maximum interincisional opening greater than 35 mm. So if the previous steps don't achieve the desired improvement in the jaw movement, opening of more than 35 mm, so similar procedure that can be done on the opposite side as well as uh, the lining of joint with the temporal fascia. So after the surgical procedure, the joint it is lined with either the patient's own temporal fascia or the articular disc of the joint that will provide a cushion uh, and the support. Fifth is the condylar reconstruction with either transport diffraction osteogenesis. So that step involves the reconstruction. The condyle reconstruction can be done either by two methods. One is the diffraction osteogenesis that involves the gradual lengthening of bone throughout the diffraction process to create new bone formation, or costochondral graft with a rigid fixation that involves a graft that can be taken from the patient rib to reconstruct the jaw joint. Early mobilization, uh, early mobilization, and aggressive physiotherapy is done. So these are the Kaban's protocol. So these protocols appear to be the structural approach for treating TMJ ankylosis, involving the surgical intervention, joint reconstruction, and rehabilitation measure to restore the jaw movement and the function. Now, why is physiotherapy so important after the TMJ surgery? Physiotherapy it helps to restore the natural movement and the function of jaw after the surgery. It prevents stiffness, enhances the flexibility, and strengthens the muscle around the joint. So let us break down the key component of the post-operative physiotherapy and how we guide our patient through it. Firstly, patient should start active exercise as soon as they can tolerate it. Initially, we begin with a gentle pressure using fingers or simple finger exercise. What comes next in the exercise? As the patient progresses, we introduced tools like ice cream sticks, tongue blades, or the Heister jaw opener. So these helps to achieve a more forceful mouth opening, gradually improves the jaw movement. What about managing pain during exercise? We may provide medication to relieve the pain, making movement more comfortable for the patient. What is the role of heat in this process? Well, heat application to the jaw region before exercise helps to relax the muscles and reduce the spasm. It makes movement easier during the exercise and helps to alleviate any discomfort. So encouragement and regular follow-up, they are the key. Patient need our support and guidance to stay motivated and committed to rehabilitation journey. Now, what are the graphs that we can use, uh, and what are their goals? So, our primary aim is to replicate the joint normal structures as closely as possible. Secondly, we strive to ensure that the reconstructed joint functions properly. And third, in case involving the children, we create an environment within the joint that allow for the adaptive growth. That is why we choose costochondral graft. They are most widely used autogenous graft for the TMJ reconstruction. So the costochondral graft, they are made through incision in the inframammary region, and 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 typically it uses fifth, sixth, and seventh rib. The segment of the rib chosen include the costochondral junction and suitable length of the rib itself. So the overall length of the graft, it would depend upon the height of the ramus that need reconstruction. So it is important to include at least 1.5 centimeter of the costochondral junction in the graft. Now, why is the right sixth rib often chosen for harvesting in surgeries? Firstly, aesthetically, The incision made to assess the right sixth rib can be placed within the inframammary crease. So that location is cosmetically advantageous as it is less visible and it promotes better healing post surgery. Second, compared to other ribs, the sixth rib on the right side has fewer muscle attachments that make it easier to assess and harvest without affecting the surrounding tissue significantly. So, are there any other reasons for preferring the specific rib? Well, the length of the right sixth rib is typically adequate for most surgical needs. That is a crucial factor when considering it as a use as a graft. So lower lips they can be considered for harvesting, but they have increased muscle attachment that can pose challenging during the surgical process. That is why the sixth rib is often chosen. So how is graft prepared and fixed? The graft it is carved to mimic the shape of the condylar head. After preparing, the graft is secured on the lateral aspect of the ramus using screws or the transosseous wires that allows a smooth movement. A gap of around 0.5 to 1 centimeter it is maintained between the graft and the glenoid fossa. So there are disadvantages to consider. Firstly, it takes a longer operating time. Additionally, there is an extra surgical site to manage complication at the donor site such as pneumothorax, that is the air in the chest cavity, pleural tears, or pleuritic pain can be disadvantages. So, why the costochondral graft they are most commonly used? Firstly, it widens it. It is chosen because it possesses a cartilage cap. So remember, it possesses a cartilage cap that replicates both the bony and the cartilaginous component of the joint. That allows it to closely mimic the natural joint anatomy. Additionally, it has an inherent growth potential, which is particularly beneficial in pediatric cases when the jaw it is still developing. So it is more easily accessible and adaptable for surgical use. Is there any chances of re-ankylosis after using the graft? Yes, re-ankylosis or reoccurrence it can occur around 5 to 39% of cases. That are the chances. So surgeons take precautions to minimize these risks, but they need to weigh the benefit against the potential complication and discuss them with the patient before proceeding with this graft type. Apart from that, there are we can use the sternoclavicular joint. It is taken from the superior portion of clavicle as it contains a cartilaginous cap. It has a potential for growth and a probability for regeneration at the donor site. The limitation are there is unacceptable location of the surgical scar. Sometimes the location of incision for the graft might be considered aesthetically or functionally unacceptable. Other important region is the iliac crest region. So remember, the anterior iliac crest graft they are preferred as they can be harvested without changing the patient position. The graft from the anterior iliac crest it is better suited for the large mandibular defect, providing ample bone material for reconstructing the significant portion of the jaw. The limitation are the donor site complication, second surgical site, etc. Other is the use of fat grafts in preventing the heterotropic bone formation. The Laurie Wolford introduced a technique using placement of autogenous fat graft around the TMJ prosthesis. So additionally, pellicle buccal fat grafts they are also utilized for the similar purpose in preventing the heterotropic bone formation around the TMJ. So this technique involves using a fat graft from the patient's area and to address the dead space around the joint prosthesis. So what is the primary rationale for the utilizing these fat graft? It is to eliminate the empty space surrounding the TMJ uh, prosthesis. By doing it prevents the formation of blood clot or hematoma in that space. So blood clot or hematoma in these area can calcify over time. That can lead to heterotropic bone formation. So this unwanted bone formation can restrict the joint movement and hence cause pain and negatively impact the function of TMJ. So the placement of autogenous fat graft or pedicle buccal flat graft, we aim at filling the voids around the TMJ prosthesis that will prevent the formation of blood clots or hematoma that could eventually calcify into the heterotropic bone. Now, what are the factors that will prevent ankylosis? So, uh, during surgery, a thorough removal of ankylotic mass it is important. That involves the complete excision or cutting out the fused joint to allow proper joint movement. Second is condylar and disc reconstruction. Studies have shown that restoring the vertical ramus height by reconstructing the condyle and disc using various interpositional material, it lowers the chances of re-ankylosis. This reconstruction also helps to maintain the proper height of the jawbone. Coronodectomy, it can be either ipsilateral or contralateral. So some surgeries involves removing a part or all the coronoid process. So that step it is important if the coronoid process restricts the mouth opening significantly. It can be done on the same side as affected joint or on the opposite side. Other is after removing the ankylotic mass, it is important to fill the remaining space around the joint space with the tissue using a buccal fat pad. That is a tissue that is found in the cheek area. So that prevents the hematoma and prevent the heterotropic bone formation. So that can even lead to re-ankylosis. In long-standing cases where masseter muscle is too rigid or enlarged, surgical procedure might involve elevating or partially removing this muscle to restore the proper jaw movement. Post-surgery post-surgery engaging in jaw exercise and appropriate physiotherapy, it is very important. These activities it helps to prevent the reoccurrence of ankylosis by maintaining the joint mobility. Now the post-ankylosis facial deformity after the TMJ ankylosis, various facial deformity can be seen that can be micrognathia, that is the undersized lower jaw, or reduced facial height, shifting of chin toward the affected side, occlusal discrepancy in case affecting one side, tilting of the occlusion plane due to the underdevelopment of the jaw on that side, that can result in secondary deficiencies. So the treatment that we can consider is either one-stage surgery or multi-stage protocol. The one-stage surgery involves a single surgical procedure that includes both the release of TMJ ankylosis and correction of the associated skeleton deformity simultaneously. Whereas in multi-stage, initially the ankylosis is surgically released. Subsequently, another phase might involve ortho treatment to line the teeth and prepare the jaw for further correction. Then separate surgical phase, secondary deformities such as facial asymmetry or jaw misalignment can be corrected. So these are the advantages and disadvantages of the disadvantages of the one stage and the multi-stage treatment. Now, how can you manage TMJ joint ankylosis in patient with obstructive sleep apnea? So remember the severe AHI that is greater than 30 and a reduced pharyngeal airway space can cause compromised airway during the jaw exercise. That can lead to choking sensation, causing discomfort and reduced compliance with the active jaw physiotherapy. Remember the AHI, it stands for the apnea hypnea index. So that is important in measurement in the sleep medicine that is used to assess the severity of the sleep apnea. So it is calculated by the dividing total number of apnea that is the complete cessation of airflow at least 10 seconds and hypnea that is partial blockage or reduction in the airflow by total sleep time in hours. So remember AHI of less than 5 is normal, 5 to 15 refer to mild sleep apnea, 15 to 13 refer to moderate, and greater than 30 it's severe sleep apnea. On other hand, PAS, that is pharyngeal airway space, that refers to the space within the pharynx, the part of the throat that is behind the mouth and the nasal cavity, that allows air to pass through during breathing. So reduced PAS can contribute to airway obstruction during sleep, leading to condition that is known as obstructive sleep apnea. So a narrower or reduced PAS can increase the risk of airway collapse, blockage, restriction during the sleep that can exacerbate the symptoms of obstructive sleep apnea, such as snoring, fragmented sleep, daytime sleepiness, and pause in the breathing. So in patient with the TMJ ankylosis, micrognathia, and obstructive sleep apnea, a reduced PSA can further complicate the management of the condition by exacerbating the airway space and influencing the treatment decisions, such as approach to jaw exercise and surgeries uh, to address the underlying issue.